thank you to Patrick for that that talk. I was actually David Moffat's fellow after following Philip Chang, so after the back of 1999, and I have to say that very much taught me how to do skull-based surgery, and he was a great teacher and a great surgeon and a great man. So we're going to have a quick gallop through the basics of vestibular schwannoma diagnosis and management. So vestibular schwannoma is not a common tumour, occurring in perhaps 1 in 50 to 1 in 100,000 a year, and the incidence is potentially rising. It may be because more and more people are getting scanned, that we're identifying these tumours at smaller sizes, and there's a wide variety of pathology. So from really quite a large tumour to tiny tumours that here you can see in the internal auditory canal, and the size of the tumour isn't necessarily a guide to the amount of symptoms that these patients get. These are benign tumours, okay, so it's not a cancer. There's a variable growth rate. A lot of them don't grow, as we'll come on to talk about. The ones that grow probably average 0.5 to 1 millimetre a year, but again, there are some tumours that grow very quickly, and you can really find some surprises. The post-mortem incidence may be 0.6%, even 1%. This is a study by Schwannoma, and they make up 80% of the lesions in the cerebellopontine angle. The majority of others are meningiomas. Classically, there are 4 stages of growth of vestibular schwannoma. So the first group, which is the intracanalicular group, tends to present with hearing loss, associated tinnitus, and vertigo of various amounts. So this is the first stage. It does to some extent depend where they grow. They may arise right here at the porus, and if they grow internally, then you get more symptoms early on. But the problem is if they start to grow in the cerebellopontine angle in the cistern here, then hearing, it says here that hearing may be worse, but the hearing loss may come later, and they may have relatively limited hearing loss. The vertigo tends to diminish as vestibular function is gradually lost, and they may have a localized headache. The third stage, which is the brainstem compressive stage, the patient then starts to become unsteady. They may well get trigeminal symptoms from compression here of the trigeminal nerve, and they may become ataxic. And then the final stage for vestibular schwannoma growth is the hydrocephalic stage, where essentially the fourth ventricle is obliterated, third and fourth ventricle obliterated, and you get raised intracranial pressure, a much more generalized headache, loss of vision because of papilledema. You may well have associated lower cranial nerve dysfunction. Patients presenting like this are rare, but they still happen. So how does vestibular schwannoma present? I mean, this slide, this has got a number of studies going back to the end of last century, and you'll see that hearing loss diminishes a bit as time goes on, but the vast majority of patients do present with unilateral hearing loss. They may have vertigo, they may have sensory disturbance, they may have swallowing difficulties. Tinnitus, of course, is associated with the hearing loss and is a variable factor, and then very rarely the signs of raised intracranial pressure. I'd like to thank Richard Irving and Tom Martin for the thesis, which the reference is here, and really is an excellent piece of work. I suppose I think it's good because it seems to mirror my way of managing these tumours. But in their series, 65% of patients presented with hearing and tinnitus, and a further 21% had balance associated with that. So again, we're up at the 85 to 90% level of patients presenting with hearing and tinnitus as their primary presenting complaint. And this is what drives these patients to ENT surgeons. So how do you diagnose a vestibular schwannoma? The problem is many patients come into our clinic and have symptoms that could be a vestibular schwannoma, but they probably aren't. We did a study back in 2012 when we looked at a number of screening protocols, and in fact there were 15 protocols that we looked at in this. I've got a selection of 3 here. and people have concocted screening protocols over time. And you won't be surprised to hear that the tighter the criteria are, the more tumours you'll pick up. But then, of course, you'll do many, many more scans. And there are three that the one that I quite like is the Mangum one, which is quite simple to work out. You just need a greater than or equal 10 decibel intraoral difference between the two ears, averaging 1 to 8 kilohertz. This assumes, of course, that there's no middle ear disease. The AOT HNS has got a slightly less tight criteria, so they go 15 decibels, and interestingly, they use different frequencies. And then the Charing Cross protocol, which Rupert Obholzer and Johnny Harcourt came up with, is a slight variation upon previous protocols, and this looks at, again, about 15 decibels between the better ear, depending upon if the good ear is good, and if the good ear is bad, then you're allowed a slightly wider difference between those two ears. And essentially, that sets you off down a path of investigation. And what's the investigation? Well, you won't be surprised to hear it's an MRI scan. Your department will have different protocols for using MRI scan. The classic one is a T1 plus contrast, but this is expensive, and various different T2 protocols have been used as screening protocols. Unfortunately, one of the things you'll find, particularly when you're following these patients up, is that the radiology department always seem to do a slightly different scan every time. So it's very difficult to sort of sometimes to follow these things, because a lot of the management, as we'll come on to talk about, is serial scanning. What if you can't do an MRI scanner? I mean, the first problem is claustrophobic patients. They can be sent off to the open MRI scanner, although you may have some difficulty persuading your hospital to do that because it involves an extra cost. The other option is to do a CT scan plus contrast. This will pick up really nearly all moderate or large acoustic neuromas. The ones that it will probably miss are the very small ones, the intracanalicular tumours. And you could argue that that missing that is probably not going to miss the boat of whether or not surgery or radiotherapy or anything we're going to come on to talk about will be covered. So you end up with a patient who's got a vestibular schwannoma. What's the plan? And the options, or the things you need to consider, one is treatment of the tumour itself, of the vestibular schwannoma, and the second is the treatment of the symptoms. And this again is where ENT has got a really quite important role to play, because management of many of these symptoms falls within ENT. Everywhere now, really, these patients tend to be discussed in a multidisciplinary clinic. And that gives the opportunity to both decide what the plan is going to be and what you're going to do with some of these symptoms. So the management options tend to fall into this. It's observation, which is not really doing nothing, although it sounds a bit like it, and that is watch, wait, and rescan. Or you consider active treatment. An active treatment will either be gamma knife or some other form of radiosurgery, or it will be some form of surgical intervention. The factors that you will consider on every patient, number one is probably the tumour size. The second is the age of the patient, and it's always worthwhile considering both their chronological age and their biological age. I always remember Mike Gleason was at pains to point out, there are some people who are 60 who might live until 90. There are some people who are 60 who may live until 61. And, these are factors that are important to consider when undertaking, what can be quite a major intervention. Hearing. When I used to give this talk, hearing actually didn't have brackets around it. As we'll come on to talk about, hearing is important, but the patient does have the other ear. Patrick's already said that the patient's got two cochlears. And the potential outcome for hearing is not so good once you get a vestibular schwannoma. Comorbidities are important to consider if you're going to thinking of undertaking surgery. Socioeconomic factors. So the choice of a treatment or otherwise that you might offer may come down to work and job. One of the disadvantages of surgical intervention tends to be that the patient will be out of action for 6 weeks to 3 months. and that may have quite a factor upon what they may choose to do. And then ultimately, patient choice. So there'll probably be some discussion about this, but essentially if you choose that under 2 centimeters in the CPA, the default management is observation, you probably won't go too far wrong. There are always exceptions, but if you start with that the first thing to do is probably to observe, then you won't be too far away from what you need to do. And the rationale for observation is that there are plenty of tumours that don't grow. I mean, you'll see that the huge overlap in these figures here. And the question that I always used to ask is how come doing an MRI scan stops an acoustic tumour growing? And the answer is, which was explained to me once, is that, of course, these are benign tumours, and it may well be that the rate of cell growth and cell death is the same, and therefore they don't get any bigger. There are a few tumours that get smaller. Okay, so the trouble is you don't really know, and there's no one has yet ascertained if you can identify the patients that will continue to grow on that first index scan. So the observation pathway tends to be an index scan. We would always do a rescan in 6 months' time. I wouldn't leave it longer. Shorter than that, you're really going to probably do a large number of unnecessary scans. I've seen, in 20 years, only a few patients who've shown really significant growth, but they do happen. You will get patients who you start with an intracanalicular tumour, and 6 months later you may end up with a 1 centimetre, 1.5 centimetre tumour in the angle. And I think you know then that this is a tumour that is growing, and therefore they're not going to be continuing on the observation and watch, wait and rescan pathway. After that index scan, you would tend to scan yearly. It's always worthwhile assessing cranial nerve function, including hearing, and the assessment of hearing includes both a pure tone audiogram and ideally a speech audiogram. Because these are retrocochlear lesions, the patients may tend to lose some of their speech discrimination, and again that will may influence your thinking about the preservation or otherwise of their hearing. And then you would consider intervention with growth. And again, it's not really mandatory. If you've got an intracanalicular tumour that you measure at 5 millimetres and 2 years later it's 6 millimetres, again you have the luxury of waiting before deciding whether or not to intervene. And much of this will again depend upon your patient, their age and many other factors. Just a brief note about assessing the size of vestibular schwannoma. Essentially intracanalicular is intracanalicular, and then the measurements for anything bigger than that are taken along a line parallel to the petrous ridge. So when you talk about an intracanalicular tumour, essentially that's 0, and anything. So when I say a 3 millimetre intracanalicular tumour, that's just intracanalicular. So what are the options of treatment? Well, the one that I've got the most experience of by a long way is with gamma knife. There are other forms of stereotactic radiosurgery. Fractionation means that you do more than one treatment. It's very much a radiotherapy technique that's used more for malignant disease. Hypofractionation means giving a relatively small number of fractions. CyberKnife is a relatively new player on the market. CyberKnife is much more flexible than gamma knife in that you can treat the whole body. And if you were a radiotherapist and you would be given the option of having a gamma knife or a CyberKnife, you'd probably take CyberKnife every time because you can treat the body. But probably gamma knife may be slightly better. It's slightly more accurate. And particularly for benign tumours, you really want to be extremely precise in where you're delivering your radiosurgery to. The aim is to prevent growth, so it's not a question of removing the tumour, it's preventing it growing, because it's its growth that usually creates the problems. And certainly you shouldn't be too disappointed after starting with radiotherapy to see a bit of growth to begin with, because that is the treatment effect. And then what you may see after that is either a stabilization or a decrease in size. It can be difficult to decide when Gamma Knife has failed, because Gamma Knife is a treatment that does not always work. And you'll probably need a couple of years, 2 or 3 years, to be certain, maybe even 4 years, to be certain that it's continuing to grow. The question is the length of follow-up. So in terms of health economics, it sort of seems cheap, but you've got a long amount of follow-up going on. And the doses of Gamma Knife, of radiotherapy, have been diminished over time to try and reduce the side effects. And therefore, being certain about the long-term effects will again require a large amount of follow-up. This is a picture of a modern Gamma Knife, the Lexel Gamma Knife Perfection, and the sources are in here, cobalt sources, and the patient lies on this bench, and this is wheeled into the Gamma Knife, and then the treatment takes place. So what happens is that you have the patient has a frame fitted. This is actually another one of the reasons why radiotherapists are less keen on Gamma Knife and prefer CyberKnife, is because they don't like the idea of having to screw something into the patient's head, which is usually done under local anesthetic. But in fact, some changes have been made such that you can actually now fit it with a face mask. But the idea is that you have something attached to the patient, you then get another MRI scan, and then you know exactly where the tumor is in relation to the frame. And the patient and the frame is attached to the bed, and the bed goes into the machine. And this is the bit where the skill is in terms of planning the dose, and you try and get the dose as conformal as possible. So you really want to treat only the tumor and nothing surrounding it. As you'll probably all be aware from radiotherapy, there is a bit of shadow, or a bit of light that comes off the penumbra. So it's not possible to purely treat the tumor, but you want the dose that's given to not the tumor to be as limited as possible. And this is critical to subsequent complications. So particularly in terms of Gamma Knife, if you're trying to preserve cochlear function, then you want to make sure, for example, that you only give about a maximum of 4 gray to the cochlea. But again, as we'll come on to talk about, the problem is that you are still irradiating radiosensitive structures. And although you may think that you've got away with it to start with, the problem is as time goes on, you start to get diminishing neural function in the cochlea. So the early series used 16 to 20 gray to the tumor margin, but now with better planning software, the doses tend to be about 12 to 13 gray. And the risks are that it doesn't work. There is a risk of facial palsy. There's a risk of trigeminal neuropathy. Again, if you're treating an intracanalicular tumor, that would be much less likely because the trigeminal nerve is some distance away. Hearing loss certainly happens. Misadministrations, you can shoot and miss. This is pretty rare. And then there's the risk of malignant change, which is probably between 1 in 1,000 and 1 in 10,000. Most of the malignant change tends to be in the condition NF2, and really this talk is much more focused upon sporadic vestibular schwannoma. And the results quoted from the best series tend to be 95 to 97% control at 5 years. It may diminish after that. A facial neuropathy rate of 1% or less, and about 3% with trigeminal neuropathy where the tumor is touching the trigeminal nerve. We then move on to microsurgery, and microsurgery is what I learned at Cambridge. Microsurgery has diminished as time has gone on. Patient preference and treating team's preference has tended to move towards radiotherapy, and the numbers of surgeries that are performed gradually decrease as time. The problem is with any patient with a vestibular schwannoma is that your surgery is unlikely to make them any better. The best you can hope for is not to make them worse. There are 3 approaches. So the classic neurotological approach is the translabyrinthine approach. The retrosigmoid approach is a bit more favored by neurosurgical teams. The middle fossa approach I put in here, again, that's sort of really gone off the radar for for vestibular schwannoma treatment. I mean, middle fossa approach still has relevance for lots of other things, but the middle fossa approach was really for treatment with the aim of hearing preservation of small tumours. And as we've discussed, these now tend to be treated with gamma knife radiosurgery. One of the problems with the middle fossa approach is that sometimes the first thing you'll find when you expose the middle fossa, the internal auditory canal, is the facial nerve, because that sits in the upper part of the internal auditory canal. So here's a brief guide of the retrosigmoid approach. So you're behind the sigmoid sinus. A craniotomy is made. You allow the CSF to come out. You retract the cerebellum, and then you've got quite a good view into the tumour. But the problem you can see here, these pictures come from one of Rob Jackler's books, who is in UCSF, where I was fortunate to spend some time. The problem here is that there is some difficulty getting towards the lateral end of the porus without drilling some bone away. And drilling bone dust in the CSF space certainly does seem to contribute towards post-operative headache. The neurosurgeons may prefer it because it's quicker, and essentially they may not need an ENT surgeon to come and help them. The translabyrinthine approach offers a direct route to the internal auditory canal. It allows you to control the lateral end of 7. So again, with that picture that the video that Patrick showed, that very much showed being able to identify the facial nerve. There's less cerebellar compression. The drilling is not intradural. There may, however, be a higher CSF rate, and it's probably a slightly longer approach. Neurosurgeons, they may like it because they've got an ENT surgeon to do the heavy lifting at the start, but they may not like it because they have to rely upon an ENT surgeon. So the outcome of surgery, there is a mortality rate, 0.5 to 1%. Surgery now does tend to be skewed towards larger tumours, so the results inevitably are less good. Quality of life tends to show that surgery offers less good quality of life. The facial nerve outcome will be dependent upon size. If it's small, then you may get a 90% House-Brackman 1 or 2. But the problem is House-Brackman 2 is not House-Brackman 1. And that can be an issue. I've put functional surgery here. Functional surgery is really more the idea that you may debulk and make a large tumour much smaller and consider giving gamma knife or something similar to the residual. And that certainly seems to be the way that many people are going. It certainly is possible to remove all the tumour or leave a very small amount of the capsule along the facial nerve, but your facial nerve results will probably be worse with that. So we mentioned about hearing. So what about hearing? Vestibular and schwannoma and hearing, it's the holy grail. This again is really a whole talk. But the bottom line is if you get a vestibular schwannoma, you are likely to lose the hearing in the affected ear. I'm sorry, there's a lot of reading here, but this is quite a good article. The reference is down the bottom. And it's the Congress of Neurological Surgeons. They did a systematic review. And the problem is, if you do observation, if you don't do anything, if you've got serviceable hearing, at 2 years, it's pretty much likely to be the same, but it's likely to go off as time goes on. Radiosurgery, which is promoted as a way of trying to preserve hearing, sort of doesn't work that well. And that makes sense. You're irradiating a tumour, you're irradiating a nerve, you're irradiating a cochlea, and you're irradiating the blood supply to it. And we all know that the effects of radiotherapy last really forever. And that's why the hearing tends to go off. And hearing preservation surgery, it tends to be that it is possible to do hearing preservation surgery, but it's quite a difficult trick. There's issues with vascularity and blood supply, and part of the problem is that the cochlear nerve is not tightly attached into the cochlea, so some traction from lateral to medial on the cochlear nerve is quite easy just to pull it all out of the medullus. So in summary, What's easy is a small tumor in an old patient, you're going to do nothing. A big tumor in a young patient, you're going to offer surgery if it's too big for gamma knife radiosurgery. The more difficult ones tend to be the medium tumors in young patients, potentially with good hearing. And if you've got a big tumor in an old, unfit patient, what do you do?
Thank you very much, Mike.
I'm sorry, there's a bit of a gallop, but I've sort of done it to time.
No, it's great. It's difficult to cover it in a relatively short slot, but you did a great job. Thank you. We've had a couple of questions. The first question, which I think is really important, is can you differentiate clinically between a vestibular schwannoma and a facial schwannoma? And if you can't differentiate clinically, can you differentiate radiologically?
Well, I think usually you can. Facial neuroma tends to be very much at the geniculate ganglion. You tend to get some bone loss. The appearance is rather more characteristic. It's pretty rare to get facial dysfunction with vestibular schwannoma. I've only really seen it with very large tumors. And sometimes if they have a large capping cyst or something like that that puts traction on the nerve itself. Whereas with the facial neuroma, you're much more likely to see some facial nerve dysfunction early on with a pretty small tumor. So I think the answer is yes. I think with a combination of radiology and the clinical history, you should be able to have a pretty good idea. And again, the question is, what are you going to do about it? And observation tends to be the initial thing to do, and you just see what happens.
Yeah, and I think the other thing to say is that that's where contrast enhanced imaging can be helpful, because you can sometimes see enhancement of other parts of the facial nerve which you wouldn't necessarily pick up on a non-contrast scan, and that can give you some indication of it being a facial schwannoma.
Yeah, I'm very much guided by the radiologists. We probably all know that patients come and see you clutching a scan and a report, and they ask you for your opinion. And despite the fact it's had a professional who spends their entire life looking at scans and writing a report, they still seem to expect you as a surgeon to come up with a better answer. And, when you talk to our radiologists, they know so much about radiology.
Yeah, absolutely. So are there any predictors of growth in terms of symptoms? You talked about not having any radiological way of predicting whether they're going to grow, but
I don't think so. I think that the only way to predict growth is to see growth. The trouble is the symptoms vary widely between, you see patients with very small tumors who are very dizzy. There's quite a large coexistence of headache disorder amongst these patients. There are increasing number of patients who essentially have had a scan for headache disorder, migraine probably, and they end up having a small vestibular schwannoma picked up, and you can almost see the referring physician rubbing their hands with glee that they've managed to they've identified acoustic neuroma. That must be the cause of their symptoms, and they send them off to you. And a lot of the time that's not the symptom. So you may have a different view, but I think it's the only way to guarantee growth is to see growth.
Absolutely. Just one quick question, because it's 10 o'clock, but Sean raised a very interesting point. You said that patients that can't have MRs for claustrophobia or for whatever reason would have a contrast enhanced CT. If that's negative, but they've got a unilateral hearing loss, would you then rescan them again at some point just to make sure that they haven't got a growing tumor that appears?
I think you probably, they are difficult. As we discussed, there are so many patients who have these symptoms who don't have vestibular schwannoma. I think it's worthwhile. I don't think it's worthwhile saying to the patient, "You've had a negative CT with contrast, you're fine, go away." I think I would see them back. I wouldn't be in any rush to see them back again. I wouldn't be in any rush to do another contrast enhanced CT scan. But I think these are the ones that present some difficulty. There are fortunately not very many patients. So it might well be the pacemaker patient. So it's likely to be a much older patient. You've ruled out, a reasonable sized tumor or small tumor in the angle. You know that they've either got nothing or they've got a small intracanalicular tumor. And that is highly unlikely. We mentioned about rapid growth. the patients that I've seen rapid growth in do tend to be younger.
Yeah.
It's very rare to get a 70-year-old who turns up with an intracanalicular vestibular schwannoma, and 6 months later they've got, you know, a 2-centimeter one. I've never seen that. I don't know if anyone has. There probably is an example somewhere. But so I would follow those patients up and think about doing another scan at some stage down the line. That would be the safest way to do it.
Okay, great. Thank you, Mike. That was really good.
Someone's mentioned about things like ABR and speech audiometry. So again, back in the day, there were lots of papers written about doing ABRs and these things, but all these things do is that they diminish your chance or increase your chance that you've got something wrong. So they don't you cannot diagnose it with an ABR. It's just a way of selecting which patients might go for MRI. And this goes back to the time when MRI was expensive, but now, you know, doing an ABR is more expensive than just sending a patient for an MRI. Great, thanks.
Yeah, thanks.